It's a pleasure to be with you this morning. My name's Michael Sears. I'm described as an e-patient. I'm not quite sure what that really means, but basically I've been a patient since the age of 12 when I was diagnosed with incurable bowel condition Crohn's disease. Wind the clock forward nearly 30 years, intestinal failure, and I became the 11th patient to have a bowel transplant in the UK. And I'm very actively involved in the digital health space and was probably responsible for the severe ticking off that my surgeon got when he decided to start tweeting me live my blood results, which was an interesting. But you're not really here to hear from me this morning. You're here to hear from the gentleman on my right. And it's a great pleasure to introduce Mark Davies. Up until literally 2 or 3 weeks ago, Mark was the Executive Medical Director for the Health and Social Care Information Centre within the NHS, basically the major government body in charge of big data within the NHS. Mark is also a practicing GP, and he was previously the National Clinical Director for the NHS on Connected Health, where he established clinical content services and remains the Senior Responsible Officer. Prior to being Medical Director, he also was GP in one of the largest GP urgent care organisations in the country and has been involved in reforming emergency care agenda in West Yorkshire in the north of England. So, it's my job to ask you a few questions today about the big data. But I'm going to start and feed you a very nice, easy one. Can you just give us a brief history as to the landscape of data within the NHS as it sits at the moment in the UK?
Yeah, sure. So apologies for colleagues from the UK who are in the audience, because I guess you'll know all this. But it's a great mistake to think of the NHS as being a single organisation with a single data structure. It's much more like a complex network of providing and paying organisations that are linked together through a kind of financial framework and a governance framework. And as such, the data landscape is different in different bits of the NHS. So just by way of summary, if you look at primary care, our general practitioners, family physicians, most of those have been using electronic health records very deeply. Many of them have been paperless for 25 years, a long time, so very rich, very deep data, very close to the clinical process. But that data has not been used, generally speaking, for purposes other than direct patient care and tends to be locked in within that point of care. In secondary care, we have data that flows much more readily and is used for other purposes, but that data is, although it contains some clinical information, it's considered administrative data. It's used for financial flows around the system in secondary care. It's known as hospital episode statistics. We've had it since 1984, and by virtue of the fact that we have universal registration in the NHS, and we have a cradle-to-grave record, it represents a very significant amount of data, in fact, probably the largest data repository in the world. Other aspects of the NHS, such as community services and indeed social care, are a little bit further earlier on in the curve in terms of adoption of electronic health records, and therefore the data there is on a much earlier part of the story.
So I guess my big question is, big data the holy grail? Is it really the big deal for the NHS?
So clearly not. And I suppose I'm going to answer that question by talking about little data. So I don't actually like the phrase big data very much. It sounds like Big Brother. It sounds scary and threatening to me. But I suppose I see this as well. Let me say it this way. I think the two most interesting scientific breakthroughs are the telescope and the microscope. And the reason those things were so significant is they changed our perspective. They changed how we view things, and they led to us asking questions of scale, and they led to a much more deeper understanding of our world. The microscopes allowed us to drill in onto very, very specific things and opened a whole area of fundamental questions around biology and the nature of things. And this telescope opened up us to the enormity of the universe, and actually it was quite a humbling experience, I guess, and we realised, our part in how things fit together. And I see big data and small data very much in that regard. So small data is patient data, individual patient data, patient-generated data, and I think that's enormously exciting, and it relates to the larger data agenda. The big data is obviously that data as it's linked together and produces a landscape that reflects the real world. Currently, we have an information landscape, I guess, in the NHS that is made up of organisations and made up of institutions. And actually, if you're a patient, I guess you'd agree with this, Michael, that isn't very important to you, you know.
No, I mean, listen, we go to a lot of conferences, you speak at a lot of conferences, data is always on the agenda and always talked about, but I guess I'm just thinking, when is it going to really affect me? When is big data going to make a difference to my daily life?
Right, I think it's happening now. So I think there are some really exciting things that are happening in the NHS at the moment around the linkage of data and the improvement of visibility of individual patients and individual people, communities, around the quality of services that are being provided for them. So I'll give you a concrete example. So a couple of years ago, I was involved in the largest open healthcare initiative in the world. And what we did is we took the prescribing data from every GP surgery in the country, and we released it as an open data initiative. So we stuck it on the internet. And this went down to the finest level of granularity in the BNF, so this is right down to kind of preparation level of individual drugs. Obviously, we didn't go down to individual patient level. This was aggregated at the practice level to ensure that no one's confidentiality was breached. But we put that data out on the internet under an open government license. That represented something of the order of about 14 million lines of data a month. So this is pretty big data. And what happened was people took that data, they analysed that data, and they started asking some really fundamental questions about the unexplained variation that happens in prescribing across the country. And that has led to real changes in prescribing practice and some questions around why some best practices in prescribing are not being adopted universally across the country. Now, I see that as democratisation. You know, I see that as a shifting of power from the service to the public, from professionals to patients. And where, if information is power, actually when you start sharing information in an accessible way, do you know what? You share power. And I think that's really important.
Yeah, I agree. I'm just wondering whether the NHS can really cope with opening up that data, whether our system actually really, because you know, we've spoken many times, transparency, that openness for me is key as a patient, and data is a vital part. But does our organisation, does the healthcare system, can it even cope with that data?
Do you know, I think that's a really good question, and I don't think that it can carry on without it. Okay, so I'm going to get a bit contentious now. So I no longer work for central government, so the shackles are off. So, I honestly think that most healthcare systems in the world have reached a point of crisis where they cannot carry on doing what they currently do. A point of crisis because of a couple of reasons. Firstly, they're operating in a macroeconomic environment, as we all know, that's very challenging. We have a rate of escalation of the cost of healthcare in almost all parts of the world by virtue of the demographic challenge, increasing numbers of long-term conditions, and expensive interventions. That rate of increase in cost means that we need to change fundamentally the models of delivery. And actually that means a very significant shift in terms of a shift towards patients and the public, as I've described, but also a shift towards away from those providing care to those purchasing and prioritising care. So in many parts of the world, we have a payment system that is based on volume. You do more work, you get more money. You know, and that's great for organisations like hospitals and family physicians. It's not a fantastic way of running healthcare. We need to turn the equation around the other way so that we base activity on not only a fundamental assessment of the needs of a population, a prioritisation exercise that works out how what services we need to meet the needs of that population, and then a planning, and we do it that way around.
Okay, so let me just ask you, you've left the NHS now, so the shackles are off, as you've said, and you've talked about a change, a cultural change. We've got a new boss at the NHS, Simon Stevens, but if you were that boss, what was the one cultural shift you would make with regards to data and the use of data in the NHS? You were the boss, and you got 1 minute, because I've got many more questions.
Well, that's an interesting question. I think, well, I've got two answers for you. One is the systematic measurement of outcomes. So we need to get to a point where we are measuring the quality of care as an intrinsic part of the delivery of our services. So that means clinical outcomes, that means patient-reported outcomes, that means patient experience, and I would argue patient-defined outcome measures. And actually, we've been going for too long thinking that kind of financial flows and operational measures of healthcare are an acceptable way of describing care. They're not. We need to become get to the point where outcomes become an intrinsic currency of the NHS. The second thing I would do is it's about the mature dialogue with the public around how we use their data, and I think we've got a long way to go in terms of explaining to patients and the public why we need to do this, how we're going to use their data, how we're going to build the confidence that people feel comfortable with their data being used, and how we put them in control of their individual data and ensure we get the value that way.
And because one of the things that I hear, particularly a lot of patients, is around the data question, is the biggest barrier actually if you're using it is fear. People are always worried. You know, we have conversations on social media. Actually, probably patients share more of their data online in social media and online communities than they do in any other space, but it's never used, it's never really mined. Are there technical barriers to using data, or is it a fear, is it a cultural situation that causes data not potentially to be used?
So I absolutely don't think the limitations are technical. I think they're absolutely cultural. And we have had a culture. I see it internationally actually of fear and paranoia around data security, which I think is really very unhelpful. Patient confidentiality is absolutely the foundations of what I do as a physician, and I wouldn't want to see anything that would undermine that. But equally, we have an absolute duty to use data and information responsibly in order to improve patient care. And, you know, not to get too kind of melodramatic about this, but I think that the effective use of linked data, particularly around kind of outcomes, frankly, will save lives. And that's a conversation that we need to be having in a very sort of clear way with the general public. Quite recently, there was a review around information governance in the UK that was chaired by Dame Fiona Caldecott. And the kind of take-home message of that review was that although it's very important to maintain patient confidentiality, actually clinicians have an equal responsibility not only to maintain confidentiality, but also to share data where it's an intrinsic part and a necessary part of care. And that was that rebalancing of the equation around information governance, I think, is really helpful.
So I agree with the sharing, and if it's going to lead me to better health outcomes, it might lead, as you discussed, to better prescribing directives and decisions. Will ultimately big data just mean big profits for pharma?
So no, I think the pharma industry is an important part of our family in terms of delivering healthcare. But I am someone who sees value as the currency of healthcare rather than profits for any particular part of it. Now, you know, I think some of the challenges that currently exist in the pharma industry can be addressed by the use of real-world data and large data, particularly where it's linked at scale. And I would embrace the future that we're moving to, where we start to systematically measure the value of our interventions and have a pricing structure that reflects those values.
So what contribution, what part does pharma play in this big data puzzle? What's their key role, do you think?
So I think twofold. I think they are a very important consumer of big data, and I think we need effective partnerships between healthcare systems and the pharma industry to use our administrative and our clinical data to build the kind of real-world impact of the interventions that we do. But of course also, pharma are a really important contributor to this. They have very rich data of themselves, they have very rich analytical expertise, and I think we have been fair weather friends, frankly, of the pharma industry. That needs to change. It's not a sustainable model, and I'd like to see a position where we see a lot more cross-fertilisation between those two worlds.
One question to lead while people are thinking of their questions. Medi-Analytics, where you are now, is obviously a US company, and you're based in the UK. Who's head of the game, the US or the UK, in data? And I'm expecting the next question to come from the audience.
Very good. I'm not sure I'll answer that, actually. There are bits of the... Yeah, so you can't take the politician out of me. So there are bits of the UK, obviously, in terms of our data architecture that are very sophisticated and world-leading. What we haven't done, however, is really improve the fluidity of the data in the UK, and there are bits of the US where the fluidity is better, particularly around some of the well-encapsulated organisations like Pfizer et al. So it's different.